Eric
Okay,
Osborn.
great. All right, good afternoon. Thank you for the invitation to speak today. Here are my disclosures. None are relevant to this talk. So I'll start with this platelet receptor schematic, and I apologize if you're allergic to these. You feel free to avert your eyes for a few seconds. I won't hold it against you. But I show this because it's important to realize just how many ways platelets can be activated, and how this has facilitated the development of drugs that have blocked many of these key pathways. And we all know that aspirin and P2Y12 inhibitors are really the mainstay of antiplatelet therapy after PCI. What's maybe less appreciated is just how the pharmacodynamics can change when a patient's acutely ill. And so in that context, that's what I'll be talking about in the pharmacodynamic effects of STEMI and shock on P2Y12 activity. So here's the menu of oral agents, clopidogrel, prasugrel, and ticagrelor. Of course, ticagrelor is a reversible agent of the three, and this impacts their onset of effect, duration, and of course, once you give the agent, it's on board, right? And so, if the patient needs to go to surgery, as you saw in the last case, or has, you either have to wait or you may potentially have to accept an increased risk of bleeding complications. The new kid on the block, however, of course, is Cangrelor, and this is an intravenous infusion, and this has a lot of very advantageous properties, such as rapid on-off kinetics, and we'll talk about this a little bit later in this talk. It's also a reversible agent. So first, I'll just go over very quickly the oral P2Y12 inhibitors. Prasugrel and ticagrelor, of course, are the newer agents. They're much more potent, achieving about 80 to 90% platelet inhibition. Compared to clopidogrel. They also act a bit faster. Clopidogrel's 600 milligram load only achieves about 50% platelet inhibition, and of course this can be variable depending on metabolism. So the newer agents are more prompt, potent, and predictable, but they still do take some time to come on board. So if we, it's all fine and well if they're given perhaps early enough, but if we look in clinical practice of when these are given, and this is for data for clopidogrel, most often they're given either at the time of PCI or after. And in this registry study, 70% of the time in STEMI patients, that's exactly what happened. Furthermore, we're becoming faster. So over time, we're taking patients to the cath lab earlier with ACS and STEMI. Our devices are better. We're getting more efficacious at implanting stents. So the stenting procedure is faster. And in my own practice, some of the quickest procedures are the PCIs for STEMIs. Of course, they have a lot of other complex issues, especially if they're in shock to deal with. But as far as implanting the stent, those can be somewhat relatively straightforward. So on the back end, we may be getting faster, and therefore there may be a longer period of time before the oral P2Y12 activity comes on board. So this is important, of course, because fortunately this is a rare event, but if you do have acute stent thrombosis, it tends to occur early after primary PCI. And so in this multi-center registry, the mean time to acute stent thrombosis was 3.4 hours, and actually the mode was only 2 hours. So most of the problems occurred early on. And so taken together, if we're giving the oral agents a bit on the later side and we're a bit faster with our procedures, there may be this gap in antiplatelet activity that we need to think about covering, especially in our sickest patients. So here's an example, and this was a patient that presented to ACS with ACS to the emergency room, was given a clopidogrel load, 2 300 milligram pills, and taken urgently for angiography and ultimately intervention. And this movie was taken 1.5 hours after the clopidogrel load. This PCI is done, antithrombotics are off, you're about to take the patient off the table, and you're sitting in the stomach as your clopidogrel load not dissolved, not offering any benefit. This is a problem. So why does this happen potentially? Well, there's certain things that we may do, and then there's other patient-related factors we can't control that can impair oral P2Y12 antiplatelet activity. One of them is sedation. Sometimes reflexively, patients come into the lab, they're given opioids, morphine, fentanyl for pain control, but this in fact delays the P2Y12 antiplatelet effect. And this has been shown in healthy volunteers with the clopidogrel load, and even in STEMI patients with newer agents, prasugrel or ticagrelor, that it's going to delay oral P2Y12 inhibition, platelet inhibition. So this isn't the only factors. There's a whole host of factors, and a lot of them surround acute illness, which compromise oral P2Y12 activity. And these can be related to intubation or vomiting, where either you can't, give the pills or they vomit the pills up. Things like shock and metabolic disturbances and organ dysfunction also can impair metabolism. And alone, these can be a problem, but in our shock STEMI patients, we in fact may have all of these factors at play, and so those patients may most be at risk of having a delayed onset of oral P2Y12 loading activity. So this was demonstrated in a population of STEMI patients that were stable or unstable, and the unstable patients were pretty sick. They were intubated in shock on requiring vasopressor support. And they did serial measurements of platelet reactivity over 48 hours, and what they found was the patients that were unstable had higher on-treatment platelet activity than the stable patients after a clopidogrel load. But what about data for prasugrel and ticagrelor? Well, in this trial, patients were randomized to receive one of these two agents, and in fact, in the first hour, there was almost no intraprocedural effect of these two agents. You may be done with your PCI at this point, by the way. And in fact, for a peak effect, in most patients, it required several hours after the initial load. This was supported by data from the RAPID trial, again, randomizing STEMI patients with primary PCI to prasugrel or ticagrelor, and at 2 hours after the loading dose, only 50% of the patients had adequate platelet inhibition, and it took 4 hours or longer for this to come on board. So what can we do? Of course, we have intravenous agents that are more prompt and potent that we can use, traditionally GP2B3A inhibitors, but the newer agent, Cangrelor, can be very beneficial, and I'll go through that here in this slide, since it acts directly on the P2Y12 receptor and essentially functions like an IV ticagrelor formulation. So both of these have fast onset. They're very potent platelet inhibitors. Cangrelor has some added benefits, however, in that the offset is very rapid. So if you have bleeding or some other issue, you can stop it, and it'll go away very quickly in less than an hour. As I said, it also inhibits the P2Y12 receptor, so it's a natural bridge to an oral agent that does the same. And in fact, it's being active at the P2Y12 receptor allows it to inhibit platelet activation, platelets before they become activated. And then finally, based on the way it's metabolized, it's friendly in patients with renal disease and also hepatic dysfunction, and this, of course, can be important in our patients with shock and metabolic disturbances. So Cangrelor, it's very simple to use. It's essentially an on-off switch that inhibits platelet activation and aggregation. So you give a bolus plus infusion, that's the PCI dose, for 2 hours or as long as the PCI is occurring. And the drug doses go up very rapidly in plasma, and the platelet are inhibited to almost near zero. And then once you shut the drug off, the drug is rapidly metabolized in the circulation by a dephosphorylation event. And within a period of 60 minutes or so, your platelets are back to their normal reactivity. So if you use Cangrelor, how do you safely transition back to an oral agent? And this is important because, of course, they're both going after the same receptor, and you want to make sure that there's no negative interaction by giving these two agents together. So this was tested in a series of pharmacodynamic studies in cohorts that all received intravenous Cangrelor infusion for 2 hours. And then they asked the question, if I give an oral loading dose of the P2Y12 receptor at the end of the infusion, is platelet inhibition preserved, or is it lost? And if it's preserved, then can I give it earlier and earlier in the infusion and remeasure platelet reactivity? And in that way, they were able to obtain this data, which essentially showed that the combination of ticagrelor plus Cangrelor demonstrated the greatest amount of platelet inhibition across the board. And that ticagrelor was safe to give any time during the infusion. So you could give it, right at the beginning or before the case even. Prasugrel and clopidogrel, on the other hand, the irreversible P2Y12 inhibitors have to be given at the end because there's a receptor level interaction that decreases the inhibitory effect of the agents together. But importantly, overall, if you compare this to platelet inactivation by just an oral 600 milligram clopidogrel load, all of these combinations of an oral agent plus Cangrelor give you better platelet inhibition throughout. So just to summarize, this is from the package insert very briefly because this is very important. Clopidogrel and prasugrel should be given at the end of the Cangrelor infusion. Ticagrelor can be given at any time during the infusion or at the end. So this pharmacodynamic data was developed in healthy patients. So of course, the logical question is, what about in actual STEMI patients? And I'll just end with this slide. So the CANTIC study, which was recently reported, took 50 STEMI patients that were coming in for primary PCI, had received aspirin. They got crushed ticagrelor in order to speed up the absorption and hopefully early inhibition of platelets. And then they were randomized 1-to-1 to receive either a Cangrelor infusion or placebo. And they measured platelet reactivity over time. And of course, it's not an outcome study. We'll have to wait for that data. But what it showed is the addition of Cangrelor to crushed ticagrelor showed an early and sustained and potent platelet inhibition, much greater than crushed ticagrelor alone. And in fact, you can see the end of the PCI is right at the beginning of this slide, and a lot of the patients still in the crushed ticagrelor alone arm had high on-treatment platelet reactivity. So I'll end here, just a quick summary. We have several oral agents. The newer agents have rapid, potent effects in most patients, especially if giving upstream enough. However, if patients are acutely ill, such as STEMI and shock, you may be inadequately covered because there may be a delay when the agent comes on board. Parenteral agents are great to use. Cangrelor is a new agent that targets directly the P2Y12 inhibitor, has very rapid on-off action and a lot of favorable dosing characteristics. And then finally, it's important to recognize when you're using Cangrelor that depending on what oral agent you're going to transition to, the loading is different. And so I'll end there and just say thank you very much for your attention.
Thank you.
Yeah, that was another terrific talk, and I think an important point that even against crushed ticagrelor, which is probably the best we can do in terms of oral antiplatelets, Cangrelor still in that early vulnerable period is more potent.